All right, so today we will finish up neuroanatomy. This is the last lecture in the neuroanatomy series. So we're going to start by talking about the thalamus. The thalamus is a part of the diencephalon. The diencephalon is at the very top of the brainstem, and it functions to kind of link the brainstem to the cerebrum. The diencephalon has a couple different regions to it. It has the hypothalamus, which is the area underneath the thalamus that you see right here. The hypothalamus, remember, is connected to the pituitary gland. The pituitary gland hangs right here underneath. The diencephalon also includes the thalamus, which we'll see here. Technically, there's a left thalamus and a right thalamus that attach to each other in the center. And the diencephalon includes the epithalamus. The epithalamus, epi means upon, hypo means below. So hypothalamus is below the thalamus. Epithalamus is this area up here that is above the thalamus. The epithalamus is where the pineal gland is. So the pineal gland is right back there at the tip of that arrow I drew. The pineal gland pokes out towards the back of the diencephalon. Actually, if you take a look, this is something we do when we dissect the brain. If you look right here, this is a deep fissure, the transverse fissure that's in the back of the brain. That's that deep groove that's between the cerebrum and the cerebellum. When you're looking at the outside of the brain, you can actually, put your fingers in there in that fissure and pull apart, right? You can separate the cerebrum from the cerebellum, and that allows you to look up in that area. So if you're looking up right in here, what you can actually visualize from the back, the posterior aspect of the brain, you can visualize the back of the brainstem, specifically the back of the midbrain. The top of the brainstem right here is the midbrain. And at the back of it, you can see the colliculi. The superior colliculus is like right here, where I've drawn in green. And then right underneath is the inferior colliculus, like I've drawn in yellow. Right above the superior and inferior colliculus, you can actually see the pineal gland. Right? So the pineal gland pokes out right at the top. And I'm going to show you guys pictures of like just the brainstem and diencephalon later so you can see this. So what we're talking about at the diencephalon is the actual thalamus. The thalamus is the largest nuclear mass that we have in the central nervous system. So the largest kind of solid mass of neuron cell bodies that we have. If you look, again, it forms part of the diencephalon. If you look at the bottom picture that we were just talking about, this rounded portion right here is showing you the nucleus. Is showing you the thalamus. So this would be the right thalamus. In the very center of that, there's a little mass called the interthalamic adhesion. That interthalamic adhesion is the little tiny mass that connects the right thalamus to the left thalamus. So if you look at this top picture here in green, that's the thalamus. So you can see that you have your right and left thalamus, these two rounded masses, and in the center, they connect to each other at the interthalamic adhesion. The third ventricle, which remember the ventricles are the open spaces in the brain, the third ventricle lies between the two thalami. So like the area between the two thalami, there's a little bit of open space that's there. That's the third ventricle. And when you look at the ventricles, like remember you see like the lateral ventricles kind of curve like that, and then you go down, and then when you look at the third ventricle, it has a little space in the center like that. The reason that there's this little part in the middle, that's where the interthalamic adhesion is. right? That's where the two sides of the thalamus are connecting to each other, right in the center of that third ventricle. The thalamus forms or is a very important relay station for fibers that are coming from different areas of the brain. Very important relay station. So, for example, signals, sensory signals that are coming into the brain go through the thalamus, and then they get sent out to the appropriate areas of the cortex. Also, signals that are coming in the opposite direction from the cerebrum can go to the thalamus before going down. So the thalamus is a very, very important relay station with signals coming in and out. We'll talk more about its function in a second. The thalamus also forms the floor of the lateral ventricle. Again, if you look at this bottom picture in yellow, I've kind of circled the thalamus itself. And then here in blue, this is where the corpus callosum is. The area between the two is the lateral ventricle. So all this area right here is the lateral ventricle. You can see that the thalamus is on the very bottom of it, forms the floor of it. So we have two thalami, right? The left thalamus and the right thalamus. They connect to each other at the interthalamic adhesion. If you look at this picture on the right, you can see that interthalamic adhesion right here. Sometimes it's also called the massa intermedia, like the mass in the middle. Each thalamus is divided. There's a Y-shaped internal lamina. This internal lamina divides each thalamus into three portions. So on this picture, you can see this kind of Y-shaped internal lamina, dividing it up into three parts. Those three parts are the anterior nuclei, or nucleus, anterior nucleus, the lateral nucleus, and the medial nucleus. So it's kind of self-explanatory, but the anterior nucleus is here in the very front. The lateral nucleus is here on the outside. And then the medial nucleus, which is also sometimes called the medial dorsal nucleus, is here towards the center. Now, those three parts get further subdivided, as you can see here on this other side, right? So this one, this colorful thalamus, or the left thalamus in this case, shows you how each of those nuclei get further subdivided into specific regions. I'm not going to go through and list them all. You can read them. This second picture here is showing you all of the pathways that are present. So like all of the connections that the thalamus has. I don't expect you guys to like memorize all of these specific connections, but what I want you to see is kind of all of the various areas that the thalamus is connected to. Again, we said it's a major relay center. So it has pathways that connect to, the auditory cortex. So auditory pathways. It has visual pathways. It has motor pathways. So like there's pathways coming from this, the info coming from the cerebellum. There's info going to the motor cortex. There's limbic system pathways. So it has like emotional functions. There's autonomic pathways, right? So that's pretty much everything that the brain does. All of these different things are somatosensory pathways. All of these are connected to the thalamus. So the thalamus is a very, very versatile relay center. One thing I do want to mention, make sure I mention, is that the thalamus is connected to the or is involved with the reticular formation and is involved with kind of being alert and being aware that somebody is awake and aware of the world. So The reticular nucleus is part of the reticular formation, is connected to all thalamic nuclei, right? So all thalamic nuclei, right? All of this sensory information and motor information and emotions, all of these thalamic nuclei are connected to the reticular nucleus. Okay, so all thalamic projections, all signals that are coming out of the thalamus pass through the reticular nucleus. So the reticular nucleus, the reticular formation, is aware of everything that the thalamus is sending up to the brain, right? Everything that the thalamus sends up to the cortex also gets sent to the reticular formation. So the reticular nucleus or the reticular formation is aware of all exiting information that's going to get sent up to the cerebrum. The reticular nucleus exerts an inhibitory control on the thalamocortical impulses, right? So like impulses that the thalamus is sending up to your cerebral cortex, the reticular nucleus has some ability to decrease those signals. It functions in such a way that is kind of compatible with the conscious experience. The reticular formation's kind of overall job is to keep you aroused or alert, to keep you like aware of the environment. That's like the main function of the reticular system. So it controls what, like how much is allowed to go from the thalamus up to the cerebral cortex, right? So it controls what you are alert to, what you are aware of, from this conscious experience around us, because you don't want to be aware of everything, right? That's kind of an important function of the thalamus as well. We refer to the thalamus as the gatekeeper, because it has some control. The thalamus and the reticular formation have some control over, what sensory information we actually are aware of. Because again, you don't want to be aware of absolutely everything that's occurring. Otherwise, you can't focus. It would be very overwhelming. And then again, when you think of the reticular formation, I want you to think of alertness, being aroused and alert. So we're talking about the thalamus, which is the largest nucleus that we have in the brain, the largest kind of massive neuron cell bodies that we have. We're talking about the thalamus and then some other key nuclei. The key nuclei are referred to as a group as the basal ganglia. So you'll hear that term basal ganglia a lot. We're just talking about some of the key nuclei in the brain. These basal ganglia include the lentiform nucleus. Technically, the lentiform nucleus has two components to it, the putamen and then the globus pallidus. So the putamen and globus pallidus are parts of the lentiform nucleus. Also, the caudate nucleus. Caudate nucleus is another of the basal ganglia. The lentiform nucleus and the caudate nucleus are both up in the area of the cerebrum. Also included in the basal ganglia is the substantia nigra. The substantia nigra is down in the midbrain, in the brainstem, and then also the subthalamic nucleus in the diencephalon. So when we're looking at these kind of basal ganglia, they have a lot of different functions. There are various functions of the basal ganglia, including primarily motor control. They are very important for motor control as well as motor learning. So like learned perfected movements that we get better at over time. There are some executive functions and like behavioral functions and emotional functions as well. Talking about, or first, we're going to look at the specific anatomy of the thalamus and these basal ganglia. The three largest nuclei are the thalamus, the lentiform nucleus, and the caudate nucleus. These are all arranged very closely to each other, like they're all in the same area. When we look at them, we'll see that the thalamus is located medially, which makes sense because remember, the right and left thalamus connect to each other in the very center of the brain. So the thalamus is located medially. Then if you go out lateral to that, you'll see the lentiform nucleus, which remember has two parts. And then the caudate nucleus is more superior to that. So you have the thalamus, then the lentiform nucleus, and above the caudate nucleus. Between these nuclei, we'll see that there are a bunch of tracts that pass through. Remember, like tracts, that's white matter. I think of tracts like wires that are carrying electrical signals. So white matter that are just carrying signals up and down. So ascending tracts are carrying signals up to the cerebrum. Descending tracts are carrying signals from the cerebrum downward. So between these nuclei, we see that there are a bunch of these like tracts, this white matter that passes through this area. That area where all of these tracts are concentrated together is referred to as the internal capsule. So between these nuclei, we have this internal capsule where all of these tracts are passing through. The tracts fan out from the internal capsule, kind of like I've drawn here, they fan out, and they end up like fanning out, like looking like a crown as they go out to all of the different lobes of the cerebrum. Because of the fact that this looks like a crown, these tracts as they radiate out are referred to as the corona radiata. Corona radiata. Okay, so here you guys can see the thalamus and then the other key nuclei that we have up here, like in the very center of the brain. So these are deep to the cerebrum, right? This is towards the center of the brain. First, the thalamus you can see in the very center, shown in purple. Remember, the right and left thalamus are medially located. Those are in the very, very middle. The lentiform nucleus is lateral to that, right? So if you go further out towards the side, you get to the lentiform nucleus. Again, the lentiform nucleus has two parts, the putamen and the globus pallidus. The putamen is lateral, like the lateral part of the lentiform nucleus. The globus pallidus is the medial part of the lentiform nucleus. Then again, the caudate nucleus is superior. The caudate nucleus is above that area. The area between these nuclei, again, is referred to as the internal capsule. And we said that that's where these fibers all like kind of pass through. Here you can see the fibers passing. Let me get a different color. Here you can see these tracts, the white matter passing through that area. And then the corona radiata is like how we refer to the fact that these radiate out to all of the different areas, all the different lobes. So like here, looking, this top picture is what we were just looking at. Again, when you look at the caudate curves around kind of like the lateral ventricle. So like don't get those two confused. The lateral ventricle is the open space. the caudate nucleus curves around kind of in a similar shape. So when you look at this picture here at the bottom, we've taken a section of this. So for example, the lateral ventricles, right, those are the open spaces that you see right here. Looking at this, you can see the same nuclei that we saw in this picture, just you can see both sides, the right side and the left side of it. So the caudate nucleus, you can see the caudate nucleus kind of beginning on here and here, and remember that like is going to curve around at the tail of the caudate nucleus. So like the tail is this bottom end part of the caudate nucleus. At the tail of the caudate nucleus, there's another kind of nuclei called the amygdaloid body, right? Amygdaloid body. So that's kind of like what this is showing you right here. This is the amygdaloid body, again, right by the tail of the caudate nucleus. So the caudate nucleus, again, would like curve around, and then you get to where the amygdaloid body is. We also see the lentiform nucleus. The lentiform nucleus, remember, is like more lateral, and the lentiform nucleus has two parts to it: the putamen, which is the outer part, and then the globus pallidus, which is the more medial aspect. Note, we don't see the thalamus in this section because of where it's taken. If you look at the top picture, this is taken like right here, and the thalamus is more posterior to that. It's back further. What else? Oh, the internal capsule. So the internal capsule is the area between these nuclei where the fibers pass through. So like if you look at this picture, you can see there's space that's present right here. That's where those fibers that are coming up are going to pass through as they radiate out. So that's referred to as the internal capsule. What else? Oh, let's talk about the corpus callosum. Above this, remember there are fibers that pass back and forth between the two cerebral hemispheres, and those fibers are part of the corpus callosum. So that's like up top here. All right, so we can see again kind of all of this same information. This picture on the left here is just kind of showing us the same stuff we've already seen, but in this case, in this section, you can see the thalamus. So here you can see the right and left thalamus, and then if you go out lateral to that, this is just showing us the basal ganglia. It's not being specific about which nuclei we're looking at, but it is showing you the basal ganglia. You can see the internal capsule. So the internal capsule is, again, just referring to like the space that we have between the nuclei where the fibers can pass through. So like the lateral aspect of the thalamus is like up against the internal capsule, right? So if you go to the very lateral side of the thalamus, that's where the internal capsule is located. Again, there are projection fibers that come in and out of the cerebrum that are going to pass right through that internal capsule. And then again, they radiate out to different parts, different lobes of the cerebrum. And we refer to that as the corona radiata. You can also see the fibers of the corpus callosum passing back and forth between the hemispheres so that they can communicate with each other. This here is just showing you all of the interconnections that are present between the different like basal ganglia, the different nuclei, as well as the thalamus. Just kind of showing you that it's all interconnected. They're all communicating with each other, We will talk more detailed about this when we talk about some disease states, specifically things that affect muscle contraction. So here on this slide, you can see all of the connections that the thalamus has with the different lobes of the cerebrum. Remember, most sensory information that's coming into the cerebrum is going to pass through the thalamus, and the thalamus will kind of decide if it should get passed on to the cerebrum or not. So this is showing us what we call the peduncles. A peduncle is just a collection of fibers, a collection of axons that are carrying electrical signals. So the anterior peduncle includes fibers that are going from the thalamus to the prefrontal cortex. So you guys know the prefrontal cortex is like behavior and personality. The superior thalamic peduncle includes the fibers that are going from the thalamus or connecting the thalamus to both the frontal lobe, here where we have our motor cortex, and the parietal lobe here where we have our somatosensory cortex. The posterior thalamic peduncle is going from the thalamus back to the both the parietal lobe as well as the occipital lobe, where we have our visual cortex. The inferior thalamic peduncle goes from the thalamus and then it goes kind of down and out, so like inferior and lateral, in order to connect to the temporal lobe, where we have our auditory cortex. These next couple slides just include a chart that talks about the different cranial nerves. We have talked about the cranial nerves a bit when we studied the structures of the head. I'm not going to go through and read all of the functions of the cranial nerves, but you guys should know the cranial nerves. Like, you should know that cranial nerve 1 is the olfactory nerve, 2 is optic, oculomotor, trochlear, trigeminal, inducens. Like, you should know the names of all the cranial nerves, and then you should also know major functions of the cranial nerves. Here, you guys can see where the cranial nerves are entering the brain. So like where the brain stem they're connecting. You guys should be able to identify the cranial nerves. There's 12 pairs of cranial nerves. Cranial nerve 1, we start at the very top and then we make our way down as we count. Cranial nerve 1, you can see here, and it's symmetrical on the sides. This is cranial nerve 1's the olfactory nerve for smell. So there's an olfactory bulb here at the top, and then the olfactory nerve continues down and in. Then here in green, you can see cranial nerve 2, right, the optic nerve. You can see the two nerves coming in from the eyes, and then right here in the center, that's the optic chiasm. Where they cross each other. Remember, half of the fibers from each eye are going to cross to the other side, right there in the middle at that optic chiasm. Then we have cranial nerve 3 here at the very top of the pons, kind of the top and center of the pons. And then you go out laterally for cranial nerve 4, right? This very, very little kind of wire here, the top lateral part of the pons. For cranial nerve 5, we move down to the kind of middle of the pons. Here you can see the trigeminal nerve on either side. Then 6, 7, and 8 are all at the bottom of the pons. And we start in the middle and work our way out. So you can see 6, then you go out further for 7. So 6 is in the middle, then 7, and then 8. Right, so all at the pons, 6, 7, 8. And then we go down for 9, 10, and 11. You just keep going straight down. So here's 9, and then 10, and then 11. is this kind of long thing that stretches down towards the spinal cord. So, and then 12, you go towards the center. 12 is like here in the middle. So let's see if we can do it this way. So here's 1, 2, 3, 4, 5, 6, 7, 8, then down 9, 10, 11, and then center for 12. Okay, finally we're going to move down the brainstem. So like at the top of the brain you have your cerebrum. Then if you go into the very middle, you have your diencephalon where the thalamus is. And then if you go inferior to the diencephalon, right below it, you get to the brainstem. Remember the 3 regions of the brainstem from the top to the bottom are the midbrain, then the pons, then the medulla oblongata, and that connects to the spinal cord. When we look at the dorsal aspect of the brainstem or the back of the brainstem, you'll see what you'll see is kind of like in that picture I was showing you when I was talking about dissecting the brain, how you can kind of pull it apart and you can look in and see the superior colliculi and inferior colliculi. On the dorsal aspect of the brainstem, there are peduncles, right, which remember are like tracts of white matter that connect the brainstem to the cerebellum. And this allows for information to be sent to and from the cerebellum. So when we look at the midbrain, right, the kind of like first part of the brainstem, we'll see cerebral peduncles carrying info to and from the cerebellum. And then we'll also see the colliculi. So at the very back of the midbrain, the posterior dorsal aspect of the midbrain, we have 4 little bulges, 4 little swellings called colliculi. There are 2 superior colliculi and 2 inferior colliculi. Just one is a colliculus. So when you look at the back of the midbrain, right, the back of the brainstem, you see 2 superior colliculi and 2 inferior colliculi. This whole area is referred to as the corpora, right, like body, quadrigemina. Quadrigemina, quad, because there's 4 of them. That area where the colliculi are is also referred to as the tectum. So like when you look at the midbrain, the tectum is the back of the midbrain. The ventral part, the front part, is the tegmentum. So the midbrain has the tegmentum in the front and then in the back, the tectum. The midbrain, we also see the red nucleus. The red nucleus is involved with muscle tone. Oh, I forgot to talk about, sorry, the function of the colliculi. So these superior and inferior colliculi are reflex centers. They are involved with auditory and visual reflexes. So the superior colliculi control our reflexes that are involved with visual stimuli. So for example, if something were to fly by my periphery, my peripheral vision, I would automatically, like without having to think about it or process anything, I would automatically turn towards that visual stimulus. That's protective, right? If something's flying at you, you need to look and, dodge it or look and catch it or whatever quickly. That reflex is controlled by the superior colliculi. Because it's a reflex and it's fast, the visual info comes in and you automatically have motor info that goes out. It doesn't have to come all the way up to the cerebrum and get processed and sent all around. It's a fast reflex. The inferior caliculi have reflex centers that are involved with auditory stimuli. So if right now you heard, bam, 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 bam on your door, you would automatically stop and turn towards it, right? Like it would be quick. You don't have to process anything or think about it. It's an automatic reflex. That's protective. That auditory reflex is controlled by the inferior colliculus. Okay, I think that's all I wanted to say. The red nucleus, again, is involved with muscle tone. And then we also in the midbrain have the substantia nigra. The substantia nigra, remember, is included in those basal ganglia. The other basal ganglia that we talked about were up higher up in the brain, but the substantia nigra is included in the basal ganglia. The substantia nigra is a dopaminergic or has dopaminergic neurons, and it plays a role in modulating movement. We talked about that a little bit when we talked about Parkinson's, but it has a role in modulating movement, and then it also has a role in reward. So like natural reward systems in your brain that, kind of make you more likely to do behaviors. All right, so now we're moving on to the brain. Moving down the brainstem from the midbrain to the pons. Keep in mind, really quick, guys, some of the structures that are in the midbrain continue down into the pons. So like the midbrain and pons are very closely related to each other. So like some structures you'll see just pass right down. So the pons is seen forming the upper half of the floor of the fourth ventricle. So the fourth ventricle is kind of between the pons and the medulla, and the cerebellum. It's between the two. The ventral region of the pons that has the cranial nerves on it, like the front of the pons that has the cranial nerves on it, is also sometimes referred to as the tegmentum. So the tegmentum also refers to the ventral part of the midbrain. Okay, so the front of the midbrain and the front of the pons could be referred to as the tegmentum. The dorsal aspect of the pons, the back of the pons, has the pontine nuclei, and then a bunch of tracts that are passing through it. The pontine nuclei are linked to the cerebellum and are involved in movement. Okay, so pontine nuclei linked to the cerebellum and are involved in movement. The pons also has the pneumotaxic center and the apneustic center. Okay, the pneumotaxic center and the apneustic center are involved in respiration, right? Both of these are involved in respiration. These are involved in altering the base respiration. In a second, when we look at the medulla oblongata sets the basic pace for respiration. But sometimes we need to change that. Sometimes we need to breathe faster, or sometimes we need to, take a breath that's deeper or more shallow. So the pons alters that basic respiration. The pneumotaxic center inhibits inspiration. Right? It inhibits the center that's in the medulla. So the center in the medulla tells us to breathe in, right? And then allows us to breathe out. Tells us to breathe in and allows us to breathe out. So it sets the pace for respiration. The pneumotaxic center sends a signal down to the medulla and it inhibits it. It stops inspiration. So it acts as a switch, right, to go from inspiration to expiration. And that allows us to alter the speed of respiration or speed up our breaths, right? So like it says, okay, stop breathing in, it's time to breathe out, so that we'll breathe quicker, right? We take faster breaths. The apneustic center increases the depth of inspiration. So when we need deep breathing, that's done via the apneustic center. So like it sends signals down to our accessory respiratory muscles. So like the internal intercostals, the pectoralis muscles, and allows us to take deep breaths. Okay, so moving down the brainstem, we have the midbrain, and then we have the pons, and then we have the medulla. The medulla oblongata is the bottom of the brainstem, connects to the spinal cord. It forms the lower half of the floor of the fourth ventricle. The central canal of the spinal cord continues up into the medulla, and it opens into the fourth ventricle. So cerebrospinal fluid that's flowing through the fourth ventricle flows through the medulla oblongata and then down into the central canal of the spinal cord. It has the multiple nuclei that are connected to the last 4 cranial nerves. So cranial nerve 9, 10, 11, and 12 have their nuclei in the medulla oblongata. So, it's related to or has functions that are related to all of the functions of cranial nerves 9, 10, 11, and 12, which remember includes cranial nerve 10, which is the vagus nerve. So there's a lot going on down in the thoracic cavity with the vagus nerve. It also contains the olivary nucleus. The olivary nucleus communicates with the cerebellum and is involved in coordination. So coordination, I'm saying like movement, coordination of movement. The medulla oblongata also has multiple centers, multiple nuclei or centers that are involved with, vital life-sustaining functions. Remember, as you go down in the brain, the functions get more like basic and life-sustaining, things that all mammals have. So the medulla oblongata is the very, very bottom of the brain. So this is like very basic life-sustaining stuff. For example, down in the medulla oblongata, we have the vasomotor center. The vasomotor center sends muscles out to control like vasoconstriction and vasodilation. It has the cardiac center. The cardiac center controls heart rate and strength of contraction. And then it also has the respiratory rhythmicity centers. Respiratory rhythmicity centers. The respiratory rhythmicity centers include the DRG and the VRG, the dorsal respiratory group and the ventral respiratory group. Again, this respiratory rhythmicity center is involved in every single respiration. This sets our basic pace for respiration. Specifically the VRG. This VRG has motor neurons that go to or controls motor neurons that go to the diaphragm and the external intercostal muscles. So it's involved with, every single inspiration. So when the respiratory rhythmicity center sends a signal down to your muscles, you take a deep breath in. You take a breath in, you inhale. So every time this respiratory rhythmicity center sends a signal, you inhale. So it sets the basic pace for respiration. The DRG is involved in the dorsal respiratory group is involved in like kind of alterations that need to be made. Okay, so here we can see the brainstem. We can also see the diencephalon. So this up here, you see the thalamus. That is the diencephalon, technically not the brainstem. So the brainstem is from there down. This first picture is at the front of the brainstem, the ventral aspect of the brainstem. So we have our midbrain up top. From the front of the midbrain, what we're really looking at are the cerebral peduncles. These right here and right here, these are the peduncles. These are the tracts that have connections that are going to go back to the cerebrum. Back to the cerebellum. And you can kind of see here, right? If you look at the back, you can see this is where those are gonna like come around and go connect to the cerebellum in the back. Then looking down below that, here I'll do red, you can see the pons. On the front of the pons, that's where we have all of the cranial nerves coming in. And then down below that, here you can see the medulla oblongata. Here, the second picture shows us the back of the brainstem, and you can kind of see a little bit more going on there, especially when we talk about the midbrain. So again, up top from all of this, that is showing us the diencephalon. So you can see the thalamus here, the right and left thalamus. You can also see right here, this is the epithalamus up top, and right in the center, that's the pineal gland. That's where the pineal gland pokes through. So that in red, that's all the diencephalon. Below that, we can see the brainstem. So the midbrain, remember in the back, has the corpora quadrigemina. That's the colliculi. So these four little like balls that I've just colored in blue, those are the superior colliculi on top, and then the inferior colliculi on the bottom. And then again, underneath that, you can see the cerebral peduncles that have, signals that are going to come back and connect to the cerebellum. Beneath that, you can see the pons. The pons, remember, is like separated from the cerebellum by the fourth ventricle. So this kind of, actually, let me change colors. This area here that I'm coloring in yellow, that's where the fourth ventricle is. And then behind that, like further back towards me, would be where the cerebellum is. And then on the bottom, you can see the medulla oblongata. Okay, these last couple slides, we'll talk about first deafness and then hearing tests that can be done. First, before we talk about deafness, let's take a second to talk about like what all is involved in hearing, because hearing is a very complicated process. It's not just the neural aspect. There's an actual physical aspect of sound waves coming in and physical, like mechanical movement of the auditory ossicles, the little bones in your ear, and pushing on that oval window. Like there's mechanical stuff that has to happen. That mechanical stuff is going to stimulate the hair cells and the neurons, and then you have the whole neural aspect that has to occur and go up to the cerebrum, and both have to be functioning in order for hearing to occur. So let's take a second to just kind of talk about the whole hearing thing real fast. First, sound waves come in to the external ear, and they go through the ear canal. Sound passes through that external ear and the external auditory canal, and then it pushes on the eardrum, right? You push on your eardrum, and then the sound goes through the middle ear. In the middle ear is where your auditory ossicles, your little bones, are moving around, and they push on the oval window, and at that point, sound goes into the internal ear. Remember, the sound waves push through, and they make that lymph move in the cochlea, right? So the waves go through the cochlea, and that ends up stimulating the hair cells, right, of the cochlear nerve. Now we have the neural aspect, right? Sound is carried, the signals are carried by the cochlear nerve, the vestibulocochlear nerve, specifically the cochlear aspect, and those sound signals ultimately are going to end up getting passed through, there's relay going on, but the sound ultimately needs to go up to the primary auditory cortex in the temporal lobe of the cerebrum. That's a lot of stuff happening, and it all has to happen right in order for us to hear. Problems along any portion of the path can cause deafness or hearing loss. The type of hearing loss depends on where the problem is. Whether there's a problem with sound conduction from the external ear to the internal ear, that's more of like a actual physical mechanical problem. Or if there's a problem with the nerve itself sending the signal to the brain, that's a neural problem. So deafness has two types. There's two types of deafness. Conductive deafness or sensory neural deafness. Conductive deafness is when there's any kind of blockage in the external auditory canal, so the sound waves can't make their way in, or if there's fluid built up in the middle ear. So for example, like if blood is accumulated in the middle ear, so the auditory ossicles can't move appropriately, or in otitis media, right? Like severe otitis media if there's pus accumulation in that middle ear. So if there's a complete, like a blockage in the external ear or fluid buildup in the middle ear, the sound can't pass through to the internal ear, which is where the receptors actually are. So that's conductive deafness. Sound can't be conducted to where the neuron is. Sensory neural deafness is when the problem is in the inner ear, in the cochlea, or with the nerve itself, the vestibulocochlear nerve. So in order for sound to actually be heard, it has to pass through the internal ear, through the cochlear nerve, and to the temporal lobe. We do not actually hear sound until it's received in the temporal lobe at the primary auditory cortex. If it anywhere in passing through it doesn't get to that temporal lobe, we do not actually hear it, right? We don't become aware of it until it's at that cerebral cortex. So any problem with the neural pathway or the internal ear will lead to sensory neural deafness. So things that can cause sensory neural deafness, for example, prolonged exposure to loud noises. Prolonged exposure to loud noises can damage the hair cells where we sense hearing. Or age, right? Age itself can cause sensory neural deafness. There are some medications, some specific medications like gentamicin, for example, is an example of an antibiotic that can cause hearing loss, sensory neural hearing loss. Some infections, there are some infections that can result in deafness and sensory neural hearing loss, or tumors. Right? If a patient has a tumor that's pressing on the nerve, that can cause sensory neural hearing loss. So we're going to talk about a couple different hearing tests that we can do to check for hearing loss and to figure out what kind of hearing loss it is. First, we'll do Weber test. So Weber test compares bone conduction in both ears. What we mean by bone conduction, sound, like sound waves are vibrations, right? It's just vibrations in the ear. And those vibrations can be kind of felt or sensed in a couple different ways. If those sound waves are coming through the air and through the ear, that's one way. But we can also transmit those waves or those vibrations via the bone. So if something's vibrating really, really rapidly and it's put on the bone, you can get the vibrations that way. So this is what we do with Weber test. So with the Weber test, a vibrating tuning fork, a tuning fork is like the little metal thing that looks like this. So when you hit it on something, right, you strike it on something, it makes it vibrate. And you can hear that, the vibrations you hear. So you take that vibrating tuning fork and you put like the bottom of it, the single part, you put it on the vertex of the skull. So at this point, there's kind of like two versions of the sound. There's the actual sound, right? The vibrations are actually making a sound. But there's also the vibration of the bone, right? The bones, your skull can feel those vibrations. So you strike it, you put it on the person's head, and you ask them how they hear that sound. If they hear it equally in both ears, right? If it's equal in both ears, that's a normal, right? They've got normal functioning, no hearing loss at all. If the person has conductive deafness in one ear, right? If one of the ears is not able to actually, take the normal sound waves through the air, then the person will actually hear the sound better on the side that has the conductive deafness. This seems really strange. But because the healthy ear is taking the normal sound waves through the air and they're hearing those, and that's a pretty light sound. But the ear that's not healthy, it's not taking the normal sound waves. Instead, it's bypassing that, and the sound is being heard directly through the bone vibrations, right? So instead of taking normal sound waves in, the diseased ear is taking the vibrations that it's feeling from the bone and it's using those vibrations as sound waves. So you hear it better on that side that's using the bone conduction. If there's partial nerve deafness, so meaning if one of their nerves is not working, they're deaf in one ear because that nerve's not working, then the sound is going to be heard better on the normal side because the diseased side does not have a fully functional nerve. So again, like the conduction isn't the problem. Whether the vibrations are being felt through the bone or heard through the ear, it's the nerve itself that's not working. So the nerve itself is not carrying the sound fully. So the other side that has a healthy nerve is going to hear better. Okay, so Rhine test compares air conduction to bone conduction, and you do it in both ears. So air conduction like when you actually hearing the vibrations through the air, that should be about twice as long as bone conduction. In order to hear the bone vibrations, the vibrations have to be bigger. If it's really, really quiet, tiny little vibrations, it won't make the bone vibrate. So, but you can hear those. So even after you don't feel, or we do it here, even after you don't feel the vibration anymore, you should still hear the vibration through the air. So what we do, we take the tuning fork, you strike it on something, make it vibrate, and you put it on the mastoid process, like the little bone process behind the ear. You put the tuning fork on the mastoid process of the ear you're testing, and they should cover the other ear because you don't want to be hearing signals through that ear. So put it on the mastoid process here, and you tell the person, tell me when you stop hearing it, right? That's bone conduction right there. Tell me when you stop hearing it, right? So they'll put their hand up, I don't hear it anymore. And then at that point, you move the tuning fork to right in front of their ear. It's got close to their ear because these are really quiet little vibrations now. But then say, again, tell me when you stop hearing this. They should hear it for, a considerable amount of time longer after the bone stops, right? So what should happen is they should hear bone conduction for a little while, and then they should tell you that stopped. You put it here, they continue to hear it, and then after a while it stops. That's normal. So in a normal person, they should hear air conduction after bone conduction is gone. If the person has, and then you do it in both sides, you test both sides. The length of time doesn't need to match in both ears. That's not what we're doing, because you might strike it harder one time than the other, right? So we're not comparing the ears to each other. We're comparing bone conduction to air conduction in this ear, and then we're comparing bone conduction to air conduction in this ear. A person who has unilateral conductive deafness, so there's a problem, a blockage in the external ear, or like fluid accumulating in the internal ear, a problem with the ossicles, they can hear the vibrations on the mastoid process, so they have bone conduction fine, but they can't hear it anymore when you put it close to their ear, right? So you put it here, yeah, I hear it, I hear it, I hear it, okay, it stopped, put it here, nope, I don't hear anything anymore. That means there's conductive deafness in that ear, right? Check the other ear too, just in case. If the person has unilateral partial nerve deafness, they're still, like, if it's partial nerve deafness, they'll hear in the air after the bone. So it's almost like it'll appear normal if it's partial nerve deafness, because the neurons are firing. There's some part of the nerve fibers that are still intact, still conducting nerve impulses. So they'll have, you know, quiet hearing through the bone, and then they'll hear a little bit longer through the air. If it was unilateral, complete nerve deafness, the nerve's not working at all, they won't hear either. Okay, so complete nerve deafness, there's no bone conduction on that side, and there's no air conduction on that side. Okay, these last couple slides, we're just going to kind of talk about a few clinical situations where there could be lesions, either central lesions or problems with the cranial nerve, and whether or not the patient's symptoms will be contralateral or ipsilateral. First, smell. Some olfactory fibers from the nasal mucosa cross to the contralateral side. So some stay on the ipsilateral side, some fibers cross to the contralateral side. So, you know, regardless of which side the lesion is on, you'll still have smell. The trigeminal nerve, so lesions that affect the trigeminal nerve transmission, whether or not your symptoms will be ipsilateral or contralateral depends on where the lesion is. If it's like a central lesion, if the problem's in the brain, or if it's a peripheral lesion and the lesion is down, down distal to the nucleus in the brainstem, if the lesion's affecting the nerve itself. So for trigeminal nerve transmission, central lesions, we're talking about a lesion between either in the cerebral cortex, so a cerebral lesion in the cortex, or anywhere down until we get to the nuclei in the brainstem. So like a thalamic lesion, for example, that's up higher than where the nucleus is down in the pons of the brainstem. So essentially anywhere between the nucleus and the pons and up to the cerebrum is a central lesion. In this case, the sensory impairment or the paralysis will be on the contralateral side, so the opposite side of the lesion. So if there's a cerebral lesion on the left side, symptoms are going to be on the right side, right, contralateral, because the signals come down from the left side of the brain, they stay on the left, but down at the nucleus, they're crossing to the right. And then you go out to the right side of the face, for example. Peripheral lesions. So peripheral lesions are lesions that are distal to the nucleus or the nuclei in the brainstem. So the nuclei in the brainstem has like the neuron cell body of the trigeminal nerve, and then the axon actually goes out to the face, for example. So once you're down to that nucleus in the brainstem, you're not crossing, you're not crisscrossing anymore. Like you're on the side you're going to stay on. So like say this is the cerebrum, right, the thalamus, and then we go down to the brainstem. We start here, say on the left, well, that would actually be the right side of the brain, but we start on, let's say, the left, right? We come down, we're on the left, and the thalamus, we're on the left, and then we get down to the nucleus and the brainstem, and we cross over to the right, and then we go out to the right side of the face. So if the problem is up here in the cerebrum, then symptoms will be on the opposite side, right? Because this would eventually cross over to the right. But if it's a distal lesion, say the lesion is down here, the lesion is affecting the nerve, for example, the trigeminal nerve, then the symptoms will be ipsilateral. So the problem is on the right nerve, symptoms are also going to be on the right. So distal lesions will cause sensory impairment and paralysis on the ipsilateral side, the same side. So for example, trigeminal neuralgia, right? Trigeminal neuralgia is a disorder that affects the actual trigeminal nerve itself. So symptoms are ipsilateral. If it's the right trigeminal nerve, then it's the right side of the face where the symptoms are. If symptoms are confined to only one branch of the trigeminal nerve, that tells us that it is a peripheral nerve lesion, or a peripheral lesion. Because if it's only affecting one little branch of that nerve, right, the problem has to be right there at that branch. It can't be higher up. If the problem's up in the cerebrum, everything downstream is going to be affected. So again, if there's, like with trigeminal neuralgia, sometimes it's just one of the nerves, one of the branches that's impacted. That tells you it's a peripheral lesion, not a central lesion. So the facial nerve is interesting. So the facial nerve, remember, controls the muscles of the face, right? So like all of our muscles of facial expression are controlled by the facial nerve. The bottom half of the face has fibers that are purely from the opposite side of the brain. The top half of the face has some fibers from the opposite side of the brain and some fibers from the same side of the brain. So let me show you what I mean here. Don't worry about like where the lesion is yet. Let's just look at the way that the fibers work. So if you look at the top picture, this is showing us the brain itself, right? And then if you look at the bottom picture, you can see the fibers actually going to the face. The green is showing you the fibers that are going to the bottom of the face. Purple showing you the fibers going to the top of the face. So for the fibers going to the bottom of the face, notice they start on the opposite side of the brain. They come down, right? And then in the brainstem, they crisscross, right? So the fibers are coming from the opposite side. They crisscross in the brainstem and then come down to control the bottom of your face. Now, the fibers that are going to the top of the face are in purple. If you look at what's happening here in the brainstem, there's a split that happens. So the fibers coming from this side of the brain come to the brainstem. Some of them cross over to the opposite side, but some of them stay on the same side, right? And then same thing, if you look at the other side of the brain, look at the ones coming from this side of the brain. These fibers come from this side of the brain, they go to the brainstem. Some of them stay on the same side, some cross to the opposite side. So when you look here, notice that there's the one, blue line or green line coming from the opposite side, but there's two purple lines coming into that facial nerve. There's some fibers coming from the opposite side, some fibers coming to the same side, all going into that facial nerve, right? And then the fibers, the facial nerve comes out and goes to the bottom of the face and then goes to the top of the face, okay? So what this means is that depending on where the lesion is, you might have complete facial paralysis on that side, or you might only have facial paralysis on half the side of the face. So for a central palsy, a central facial nerve palsy, this means that there's paralysis of the facial nerve, paralysis of the muscles, the facial nerve, but it's happening because there's a central lesion. So this is a lesion between the cerebral cortex and the facial nerve nuclei in the brainstem, which is in the pons. So again, if there's a problem in the cerebrum or in the thalamus. So this picture here is showing us a central facial nerve palsy. You can see this little black line showing us there's a lesion up here in the cerebrum. So what that means is that there's no green fibers coming from, right? Remember, the green fibers come in and they crisscross and go to the bottom of the face. So the bottom of the face is going to be paralyzed. There's also no purple fibers coming from that side, right? The lesion has cut those off. But remember, the top of the face has fibers coming from both sides of the brain. So there's still some purple coming from the other side of the cerebrum, right, that stays on this side and comes to the top. So with the central lesion, symptoms are on the contralateral side, right, the opposite side of the face, but they're only on the bottom of the face, right? The frontalis and upper orbicularis oculi muscles are still functional. So if the person can't, smile, they can't puff up their cheeks on one side, but they can raise their eyebrows and blink, that means it's most likely central facial nerve palsy of the opposite side. So if the symptoms are on the right, your lesion is in the cortex on the left. Or if it's a peripheral palsy, this means it's the actual facial nerve that's the problem, right? The actual facial nerve is the issue. So like Bell's palsy, for example, in Bell's palsy, the problem is actual facial nerve inflammation. So in that case, it's what we see here, this left side of the picture. Here you can see this lesion here. The lesion is of the facial nerve. So none of the fibers are getting through, right? It doesn't matter where they came from in the brain, none of them are actually going out to the face. So that means symptoms are complete on that entire ipsilateral side of the face. So lesions distal to the nucleus in the brainstem, for example, facial nerve, Bell's palsy, symptoms are on the ipsilateral side and the entire side of the face. Okay, eye movement and related lesions. So eye movement involves a lot. Eye movement involves multiple cranial nerves. So the trochlear nerve, which is cranial nerve 4, right? The trochlear nerve, cranial nerve 4, innervates the superior oblique. The abducens nerve, which is cranial nerve 6, innervates the lateral oblique. The oculomotor nerve is really involved with eye movements, hence it's called oculomotor, like movement of the eye. So cranial nerve 3, oculomotor nerve, innervates all of the other muscles of the eye. So cranial nerves 3, 4, and 6 are all involved in eye movement, okay? Conjugate eye movement, that's like normal eye movement, where your eyes move together, right? So like I look at the wall and then I scan over to the right side, my eyes should move together. Conjugate eye movement requires the oculomotor nerve of one side to work together with the abducens nerve of the other side, right? Because the abducens nerve is pulling is the lateral muscle. The oculomotor nerve is innervating the medial muscle of the other eye, right? So like as my right eye is being pulled laterally, my left eye is being pulled medially, right? And then the opposite is true. So the oculomotor nerve on the left needs to work together with the abducens nerve on the right, right? And vice versa. Patients with lesions of these nerves, so lesions of abducens nerve or oculomotor nerve will have what's called disconjugate gaze, right? Disconjugate gaze. The eyes do not move together anymore. And they experience diplopia, or like double vision. That's what double vision is. Cranial nerve 3 it's involved in eye movement, but it also innervates the pupil constrictor muscle. So it causes constriction of the pupil. The levator palpebrae superioris, so like elevating the eyelid, and muscles that adduct the eye. So like adduct the eye is move the eye towards the center. So lesions of the oculomotor nerve or cranial nerve 3 involve multiple signs on the ipsilateral side, so on that same side. So if there are issues with cranial nerve 3 on the right side, the right eye is going to be problematic. So because the pupil constrictor muscle isn't going to work, we'll see pupil dilation. So the pupil will be really big on that side. And lack of a light reflex. So when you shine the light into it, it's not going to constrict. The other eye will constrict just fine, but that one will not. We see ptosis. Ptosis is like a droopy eyelid because the levator palpebrae superioris is not working. And we see outward deviation of the eye because, again, cranial nerve 3 adducts the eye, pulls the eye inward, right, towards medially. Without that, you have lateral pull. The eye deviates outward. So if somebody just has disconjugate gaze, the eyes don't move together, that alone does not tell you which cranial nerve is the problem. But if they have disconjugate gaze and a dilated pupil and ptosis, that tells you, okay, it's the oculomotor nerve that's problematic. Lesions of the trochlear nerve. So lesions of the trochlear nerve will result in patients tilting their head away from the affected side. These are ipsilateral. So if it's the right trochlear nerve that's being impacted, they tilt their head away from the right side. And the reason for this is there's an inability to depress the eye when it's adducted. So like adducted is when it's pulled towards the center. So they can't look like down and in. They can't look down and in like down and in, right? Like if you were like just gazing down at your lap, they can't do that. So instead they end up tilting their head to try and compensate so they can look in that way. Lesions of cranial nerve 4 are hard to identify in a comatose patient because the behavior can't be seen, right? Like that's what we look for. We look for, if there's disconjugate gaze and double vision, and we see that, as they're like looking around, they tend to be tilting their head because they can't move their eye appropriately. But a patient who's comatose, this doesn't happen, right? Like you can't watch for that behavior, so that it makes it more difficult. Lesions of the abducens nerve, cranial nerve 6, lead to inward deviation of the ipsilateral eye. So remember, cranial nerve 6 and cranial nerve 3 move the eye in opposite ways, right? One moves lateral, the other moves medial. So cranial nerve 3 is responsible. Cranial nerve 3 is responsible for moving the eye inward. Cranial nerve 6 is responsible for moving it outward. So if one of those is messed up, the eye moves in the opposite direction too much. So the abducent nerve brings the eye laterally, right? It moves the eye outward. So if it can't do that, there's too much inward deviation instead. So the eye will be moving in towards the center. So almost like cross-eyed, but only one of the eyes is doing it. Note that cranial nerve 6 lesions, right? Lesions of cranial nerve 6 are are not associated with ptosis or pupil dilation, right? So you see the inward movement of the eye, there's disconjugate gaze, there could be diplopia, but the eyelids are not drooping, the pupils are not blown, or that pupil, one pupil is not dilated. And then again, remember for those, that's always on, for all of those cranial nerve issues with eye movement, it's always on the ipsilateral side. So whatever nerve is affected, that's the eye that's impacted. Just last kind of little note, vestibulocochlear nerve damage results on hearing loss on the ipsilateral side, right? So cranial nerve 8, if there's sensory neural hearing loss in the right ear, that means it's the right vestibulocochlear nerve that has a lesion present in it.